Okay, it's 3 o'clock.
Yes.
So we can start now. Good afternoon, ladies and gentlemen. Good afternoon to our elders, Dr. Ajeni Fuja in particular. We want to thank you for finding time to join us for this webinar. This is the third in the series that we are having, organized by the Private Practice Pediatricians Group. And I want to first apologize that we should have had this on last Thursday, but because of the clashing data and program, our presenter has requested that we should have it today. So it's my pleasure and honor to welcome each and every one of you. And today, I'm sure we're going to have a very good time. The presenter is well known to all of us. She will obviously introduce herself further as we progress. Our presenter is Dr. Ngozi Onya, my senior and my friend and my colleague. And I'm sure she will do justice to the talk for today. Before we hand over to her, I will quickly hand over to the chairman of the group, Dr. Mobodaji Lawal, for his address. Thank you, sir.
Okay, thank you very much, Dr. Eletu. It's always a pleasure for me to be at this meeting. I look forward to it so much. So I welcome everyone again, and I greet everyone, especially elders, Dr. Ajeni Fuja. Thank you for making time to be with us. This is our third meeting. And since the first time we met, we have grown from 65 to 75 in number. But I know that there are still many pediatricians who are in private practice who are not yet on this group. So I would like to encourage us, if we know of any such people, to reach out to them and encourage them to join. Maybe they don't know yet. I will repeat this call at the end of the meeting, and also to encourage us to volunteer to make presentations for the meeting. We have had very interesting meetings on very interesting subjects. Some of them, challenging and exotic. And just to say that we welcome also very simple, common, day-to-day clinical experiences and challenges as well. The topic doesn't have to be complex or exotic. Any experience that we have there's an echo coming from somewhere. Any experience that we have, as pediatricians in our practice is very useful, especially if it's challenging. So we welcome also simple, common things as well. Today's topic is very interesting, and we have an important pediatrician who is going to make the presentation. Dr. Onya is somebody I like to describe as a versatile physician. He's a pediatrician who gained plenty of experience in the corporate world as the medical advisor of Nigerian breweries, and then went on to start her practice, which has since grown. And the remarkable thing about her is that when COVID came and most doctors were running for cover, she came out gallantly and offered her services to help to save lives. And for this, I have a great deal of respect and admiration for her. So I don't know whether today he's going to touch on her experience in that area, But whatever it is, I'm very, very pleased to welcome her to lecture us today. And I look forward to how she will make us to navigate between nihilism and over treatment. You know, as they say, when do you decide to stand there, do something? As opposed to
Can you hear us, sir?
their presentation. So thank you very much. So over to you, Dr. Letu. Yeah.
Thank you very much, sir. Just before we start, I would like to advise that if we have any questions, we can use the chat box, and questions will be answered after the presentation. So I hand over to Dr. Ngozi Onya for her presentation. Ngozi, over to you.
Thank you. Good afternoon, everybody, and thank you for having me on this presentation. I'm happy that Dr. Mobolaji Lawal, who was my first, I don't know if you remember, when I worked for him in ML in Igbonri, after the copper then hustling. Okay. I'm happy he introduced me as a versatile pediatrician. So what I'm going to talk about today is not strictly pediatrics, but it's medicine. And I think, first of all, before being pediatricians, we are doctors, and primary care physicians, we should all be. We don't have enough doctors to strictly stick to specialties, I think. I think we should all be pediatricians. So I'd like to share my screen. Okay. My slide. Wait. Gosh, come on. Let me keep now. Come on. Where you were here. Sorry, please, can you share my screen for me, Sandy, if you don't mind? Because I don't want to have some difficulties now. Sandy, can you share my? Thank you. Can you please put it on slideshow? Okay, thank you very much. So this is an interesting topic. Please, next slide, please. Next slide, please. Next slide. Well, I think everybody knows me. The presentation is going to follow this format. I'm going to talk about my own physician's oath, the physician's oath I took in 1982, and then the modern Hippocratic oath that I heard, interestingly, in 2019 when I attended the induction ceremony for my friend Edwin's daughter, Professor Edwin's daughter. And I thought a lot about the new physician's oath. And then a recent experience with a child here, or the child, interestingly, thank God, not an adult this time, made me wonder about that oath, that the new modern Hippocratic oath. I don't think I will have answers. So what I'm going to do is ask a lot of questions. And I think my objective is to just raise issues, things we should think about, and, things that we should think about. Let me start by my introduction. I will talk about a little bit about my hospital and my own experience. So in 1994, I had my third and last child. She was born with Chad syndrome. I think everybody knows that. I mean, most people who know me know that. And my hospital is set up in her memory. And I remember taking her to the UK on her third day of life, where she had surgery to repair her esophageal atresia. And I remember when I was living here, one of my friends who was in hospital with me had said to me, Ngozi, doctors are very negative, as they're telling you things, just be rejecting it in your mind, be rejecting it and canceling it in your mind. But I do remember that we arrived on a Sunday. She had the esophageal repair on the Sunday. On Friday, the surgeon sat me down and told me, looking me straight in the eye with the nurse standing by him, and he will say each thing and he will wait for impact. He said to me, her left eye is blind. I think she had vision in the right eye. I don't know if Dr. Gisu is on this call, but I think she was with me there. So her left eye is blind, but I think she had vision on the right eye. Although we have successfully reanastomosed her esophagus, she still is not swelling. Swallowing. There seems to be a motility problem. She will need to be tube fed for the next 6 months. She's probably going to be mentally retarded. She'll be small. She had a PDA. He told me about 6 or 7 different things, looking me straight in the eye. And I said to him, he asked me if I had any question, and I said I only had one question. I said, doctor, if you knew all these things you are telling me now, why did you operate on her on Sunday evening when we arrived to save her life? And he said 2 things to me. The first he said to me was that first, every parent will want to do the best they can for their child. And secondly, he said to me, if I thought she was totally hopeless, I wouldn't have operated. We know the rest of the story. She lived for 9 years. She died as a result of the fundoplication she had done first year of life to reduce reflux. Then I remember again in 1992, a good friend of mine, Ifeanyi Ilechukwu, I'm sure we all remember her, did her Viva for her part 2. And I remember her coming back after her Viva and saying to us, those of us who were waiting to hear how it went, that, hey, Professor Kolo just wants to fail me. Can you imagine what question she asked me? What was the question? Professor Kolo had asked her about dilemmas, ethical dilemmas she had faced in her practice. At the time, it sounded like a wicked question. I mean, should I be more comfortable discussing sickle cell or something like that, not ethical dilemmas? But as I've grown older, I've seen the importance of medical ethics and those questions. And then this patient I saw a few weeks or months ago really, really brought those issues very, very sharply into my focus. So can you please go to the next slide? So let me define these things. So first, therapeutic nihilism is defined as, sorry, I just need to get rid of this. I don't know how to get rid of this. I should have just presented from my iPad I'm used to presenting with. Okay, therapeutic nihilism is defined as, when you say it is impossible to cure something, or when you think it is, so these are definitions from the dictionary. And it says, a certain man called Michael de Montaigne espoused the views that many cures do more harm than good. Of course, this was before things like antibiotics and so on were discovered. And I'm sure we all realize, we all agree that most illnesses will resolve on their own. And that a lot of the things we do actually are more harmful than useful. I'm sure we all agree on that. When you practice medicine long enough, you will know that. But this was, of course, before effective medications like antibiotics and so on were discovered. Now we know that when you have a bacterial infection, you must give an antibiotic. But we also know that there are many things that you can really do nothing about, and yet we go ahead and treat and treat. Okay, that's over-treatment. So therapeutic nihilism is here defined as, I think the one I want to work with today will be being inappropriately pessimistic of a patient's outcome. You see a patient, and from the minute you see the patient, you feel you can't help this patient. And it's interesting because this morning, as I was discussing this presentation with a friend of mine who's a dentist, she shared her experience about a young man in their church who they thought had disseminated cancer, nasopharyngeal cancer in his lungs. And when they wanted to do radiotherapy and all kinds of things, and the boy just disappeared and went to do something, whatever. And that now she sees him in church. For a while, they didn't see him. Now they see him in church looking very well. Meanwhile, they said he had inoperable cancer. He needed all kinds of things. Well, we haven't seen the end of that child, but it's 2 years now, 2 years later. So that kind of person, if he had come and needed to be on life support, we will have said this patient doesn't have a chance. And then we'll have given it to somebody who we thought had a better chance and put that person on life support. However, this man 2 years later is still dancing and singing in church. So, however, overtreatment is when we now aggressively treat illnesses that do not require any treatment. And I'm sure we are all very, very conversant with that practice of overtreatment. You know. And so this is my own physician's oath that I swore to. Please, can we go to the next slide and the next? Okay. This is the physician's oath I swore to. Okay. But can we go now to the physician's oath that my little girl, Ore, the modern Hippocratic oath, Ore Adejuibe, swore to. And the most important line in this second, please, the next slide, the most important line, it says, I will apply for the benefit of the sick all measures which are required, avoiding the twin traps of overtreatment and therapeutic nihilism. And I think the question, in my opinion, please, the next slide, is how do we avoid those traps? How much is too much? So I had this 14-year-old boy who came, for reasons of medical confidentiality, I won't go into too many details, but he was brought in here by another physician. By the time he was brought in here, apparently he had gone to the hospital where he had been going before, and he was turned back, he was not accepted. But he was brought in here for what appeared to be an orthopedic problem. And he came into emergency room. But in the course of managing him, first of all, we made a diagnosis of COVID, which was probably and very quickly on admission, he became delirious. So probably COVID is what pushed him into delirium. He had multiple pathological fractures. And cutting a long story short, this young man who was genotype SC had a chronic liver disease. He had had this for 4 years. He had been to at least 6 different hospitals, very good hospitals. He had been to teaching hospitals in the north, 2 teaching hospitals in the north, 1 in the west. He had been to about 4 top private hospitals in Lagos. He ended up here. And he had been managed for all kinds of things, a fracture fixed, and and I'm wondering, were questions not asked about why pathologic fractures in one child, and so on. Anyway, it was, I think at the end, we came up with the impression that he might have had Wilson's disease, but I'm not quite sure. But by the time he came here, his bilirubin was about 18. He was a very ill child, cut a long story short. And it was very obvious from the minute we admitted him that this child was not going to walk out of this hospital alive. It was very obvious. And yet he was here for a while. We treated COVID, we kept treating. There was a lot of pressure to treat from politicians, from captains of industry. I got all kinds of phone calls. Please do your best for this patient. And I remember the MD of one big company said to me, I know you always do your best, but I have to call you. I was told to call you. And I said that, and then the parents were here. The father was very distressed, very unhappy. You could see him, really totally broken by his son's illness. But from the minute not from the minute, but soon after I started managing that child, within a day, I knew that this child was not a child that we could help medically. And I think I expressed it, but I'm not 100% sure I expressed it very forcefully, because many things will come to my mind. Are you God? Who are you to determine who will live and who will die? And things like those kind of thoughts kept going through my mind. Should you take away hope from me? But I think, if I remember now, I did say to the father that I don't think we can do much medically to reverse what has happened. This child should have had a liver transplant 3 or 4 years ago. I said, but now there's little we can do medically, but of course, let's keep praying. There's nothing God cannot do. So I still gave that hope. And then we kept doing different procedures, so platelets here, platelets, fresh frozen plasma, all kinds of things. I'm sure everybody gets my drift. All kinds of things. Syringing the bladder because suddenly a mass appears from the pelvis, and it looks like, and then very little urine draining out of the catheter, and then causing the child a lot of distress. So by the time this child finally died, 2 or 3 days after about 10 days on admission, or maybe more than 10 days, maybe after about 2 weeks on admission, by the time this child died, then I'm thinking to myself, will I have been fairer to this child if I had said to him from the beginning, nothing had done, and looked him in the eye the way the doctor in the UK, Mr. Drake, looked me in the eye? Will I have been fairer to this child and to the family if I had done that? Will I have been fairer to them if I had refused to do all those platelets and things that I knew were really not making a difference? Of course, this story is being told in a very, I'm not saying all the things that came into play, the fact that he was referred by another doctor who was also managing him and telling him what to do and so on. But will I have been fairer to the child if I had just given him palliative care? And so I said, how much is too much? And how much is too little, or how little is too little? Then when do we cross that line between the physician and starting to play God and thinking we can determine when people will live and who will die? Another thing which Dr. Mobalaji Lawal alluded to was the fact that I've seen an excess of deaths because of running a COVID center. I've seen people die more than I'm normally used to in a short period of time. I've had to make very challenging decisions between, who to put on ventilator, because I started off with 2 ventilators, now I have 5, because sometimes just because of one patient, I buy another ventilator. Just because of one patient, I buy another ventilator. Then there are the issues of when it is futile to try. How much harm do we cause by trying when we know that there's nothing more we can do? Then the issue of the fact that in Nigeria, people don't have advanced directives. So yesterday I got a phone call from a colleague of mine to say another colleague's daughter, so not just colleagues, they're all medical people, but they were also my secondary school classmates. Another colleague's mother has been diagnosed with COVID. Her own daughter, who is also a medical person, is out of the country. And I said to her, how old is her mom? She said 89. I said, what is her pre-COVID condition? How does she look? How frail is she? Because I've seen that a lot of elderly people who are very frail, who are already bedridden, are brought into the center. And then they spend a long time in the center, maybe 5 days, 6 days, maybe 10 days. They run up huge bills for their parents, for their families, and then they still die, but they were 92. So how do we know when we're crossing the line into ageism? Sorry to be personal, but Paolo is about 92, but he's living a beautiful life, So at what age do we say that this person is now too old and we think the person doesn't have to live anymore? These are questions which are troubling my mind. So I said to her, we will need to have advanced directives. Should we do everything possible to save the life, even for this 89-year-old lady? How do we feel about the fact that I'm happy that Dr. Jenny Fuja, who is also not a very young person, is on this call. So, because I would like to hear people's thoughts, because we need to be careful also about ageism. I'm also getting on in age. Will I want to be written off just because of my age? But then there's also the issue of who do you put on the ventilator? Keeping people on the ventilator who don't stand much of a chance, and then having to turn away people who have a fighting chance. But do I have the right to take one person off a ventilator to put another person because I think that person has a better chance? They are the kind of questions that have been tormenting me. And I feel we should all start thinking, because now with a lot of medical technology that's able to prolong life, these are issues that will continue to confront us going forward. Then should we now always ask for advance directives when we have very ill patients coming into the hospital? Should people start writing their living wills? Before I wrote mine in 2010, and it's in the custody of Dose Afolabi, who was my partner at the time in the practice. Okay. Then, when you think about it, can you please go to the next slide? The issue of the decisions we take to avoid regrets. Now I'm looking, should we have done certain things? Shouldn't we have done something? So some things we did, should we not have done them for that child? Some things we didn't do, should we have done those? We don't know. Then you wonder which is worse, to do things you shouldn't have done or not to do things you should have done. Then again, then of course, the question of litigation now, that's also an important issue. So I've talked a lot now about my own moral values, my own ethics. But then there's also the issue of the fact that patients can sue us, even when we think we've acted in their best interest. Then of course, I started this story by telling my own personal experience. That comes into play every time I see a child that is suffering. I remember my own child suffering. And maybe sometimes I overreact, coming from that perspective of not wanting another parent to go through what I've gone through. What I wanted done for my child, is that what this parent wants for their own child, And then of course, there's always that pressure, do something, do your best. Doctor, do something. Very few parents are willing to fold their hands or willing to let you fold your hands and do nothing, even when you know it's futile to keep doing the things you are doing. Even the time you spend on what you know is futility, taking away from the time that you will have spent on helping somebody else. Then, like I said, diverting valuable resources. We know how constrained we are in Nigeria. So the oxygen is all being used on somebody who you know in the end will not benefit from it. And then what about things like end of life care? Please, the next slide. Are they things that we should start considering in Nigeria? Should we come to a point where I'm not talking about euthanasia, not ending people's lives, but just accepting that these patients can no longer be helped medically. And then, for example, that child, if I were to take back the hand of the clock, when that child came in, I would have had a very frank discussion with the family, and I would have resisted all pressure on me, and I will have encouraged us to just palliate, make the boy's life easier, reduce discomfort and pain until God calls him home. And then maybe if that parent had refused, I would have simply asked them to go to another hospital. So I will never turn a patient back. That's my principle, not because I think they will die in my hospital. I mean, patients will die in hospitals. If they don't die in hospitals, where will they die? So as long as I'm sure we have done everything we should, no omission, no errors of omission or commission, then I'm fine. I don't mind. I mean, I can live with patients dying in the hospital. However, if this were to replay itself, I would put my foot down that what this child needs is palliation, and then maybe ask the child. If the parents say no, keep trying, give fresh rodent plasma and platelets and all expensive treatment that we know will not make any difference, then maybe I will ask them to seek care elsewhere. Then I talked about the issue of ageism. I gave the example of Paula, but of course we also have our own dear Dr. Jenny Fuja in our midst, who is not young, but is living a good life. So we need to be careful about ruling people out just by virtue of age. Then, because we all pray to be old one day. Do we want to be? I remember a friend of mine who visited our uncle in hospital once here and saw the age he had entered in hospital was maybe 70 or something like that, but you knew he was about 87. And the man said when they asked him how old he was, he said 70 because he knew if he told them his real age, they will rule him out and nobody will pay attention to him. So we need to be careful about that. Then I say Hippocrates, who told us to do no harm, who told us to do good. What will he do if he lives in 2021? And I'm asking everybody else on this forum, what would you do? I think that brings me to the end of my presentation. I think it's a time for us to redefine our ethics and clarify our ethics. I think, some other notes I made after I had written my presentation, and I think I should mention them, that evidence-based medicine, when it's defined, talks about based on research and patient preference, then physician's experience. So patient's preference. So when they put pressure on you to keep treating, do we keep treating for that reason because that's the patient's preference? And then I also talked about, so I think that, so this is the conundrum I wanted to present to the House, and I think we should all address. Thank you very much. And I see Dr. Jennifer just hands up, but send over to you.
Wow, thank you very much, Ngozi. I don't even know where to start. I think, like Rita said, these are very thought-provoking. This is a very thought-provoking presentation, and we'll obviously allow Baba Jenifuja to have the first slot, and then I hand over to Orode to coordinate the question and answer session. Thank you very much.
Good afternoon, colleagues. Now, I want to thank Dr. Ngozi for a very beautiful presentation. And I put my hand up just to relate my own story. About 15 years ago, you all know that I belong to a diagnostic company. And then when we installed the first MRI, I did some tests, and the MRI showed that I had something in my abdomen. Of course, compared with all the results, I think I was 75 then. I'm 92 now. And we looked at all the things with all the professors and the doctors and the nurses. And then it was suggested, the nurse is not from here, it was suggested that they do an exploratory operation. Then I told them, I said, look, I say, I'm not going to have any operation done. I've looked at the result. I'm a doctor. If I have any chronic or malignant illness, my ASR will go up and there will be other indices. So I told them I wasn't going to have any exploration. So a few years later, I went in again for the test. And they all, that day, the day I told them I'm not doing anything, some of the nurses were shedding tears because they thought they were going to lose a brilliant doctor. I don't know whether I was brilliant or not. But a few years later, about 5 years later, they did another test. And then lo and behold, they told me the thing has disappeared. So if I had the operation done, I'll probably not be talking to you today. So my advice is, these things, we have to weigh the option very well. We shouldn't give up, but think of it. Suppose this were my wife or this myself, what will you do? So I thought I'll tell you, thank you very much for opening this new page in medicine. It's very difficult, but unfortunately, some of our colleagues don't think this way. My wife, my uncle's wife died a few weeks ago. He was 98. They wanted to do, he had somebody gave her cookies. And they wanted to do renal dialysis on her. Can you beat that? Unfortunately, the children refused. She died. So this is what we face in medicine. And I'm glad you have raised this point. And I hope everybody will take it home. Thank you very much.
Thank you very much, sir. May I kindly ask Isaac Asinobi, can you please mute yourself because you have a lot of background noise? Thank you. Thank you very much, sir. I'd like to ask Dr. Odushote. I thought I saw your hand earlier, unless it was a mistake and you brought it down.
No, it's a mistake, please, an error, please. Thank you.
Okay, thank you very much.
They should still speak.
So, all right,
Tunde
I
should
see
still
somebody. I see another hand up, and I see Elizabeth's iPad. So, and then somebody with the name I. Okay, I see Iretiola Fajolu. So can we have Elizabeth, please speak. I'm not sure who this is. Is this Dr.
Onifade?
Dr. Onifade, Cecilia, good afternoon. I'm sorry. It says, welcome. You're welcome to the floor.
I'm Elizabeth.
Yes. Yes.
Ngozi, thank you very much for your presentation. This topic is a massive dilemma, particularly if you've had relations that have been unwell and you have been told that there's nothing we can do for them. As a doctor, my younger brother had leukemia. I was in hospital and we were praying that we'd be able to transplant her. I was a perfect match for him. And we had done all the blood tests. And suddenly he deteriorated massively. And this was in Hammersmith. And they just kept saying to me, well, we have to go down the palliative route. There's nothing else we can do for him. As a doctor, I was broken. I was crying like a baby. I just kept saying to them, do everything you can. But for adult medicine, they make up their minds. Once they have decided we're going down the palliative route, it doesn't matter how much grammar you speak in this, our environment, they go down the palliative route. And they would have told every doctor, to the youngest doctor, that don't let them push you into doing anything for the patients. And we faced it squarely. It's a little different for children, isn't it? We have children who have life-limiting illnesses. And for those with life-limiting illnesses, my experience is that right from the word go, they, like Ngozi just said, you have to face them and say to them, this is a life-limiting illness. We want your son or your daughter to have a lovely quality of life. What kind of things do you think your child would enjoy? What do you want us to do to make your child achieve that good quality of life? And right from the word go, the parents are prepared. It's a difficult thing. They are prepared for the eventuality. And I have noticed that most of these children, they don't die in hospital. They die either in their respite care homes or they die in the arms of their parents at home, unless they come with an acute illness. I think as a student, medical student, as a young doctor, nobody ever trained me along those lines to prepare patients and parents for the eventuality of death. And I think it is hard. It is very hard. I don't know what Ngozi has to say about pediatrics trying to toe this line. That's where I will end my own comments. Thank you very much.
Thank you very much, Dr. Onifade. That was a heartfelt comment, and I could feel you through that. And I'm sorry you had to go through that. And thank God you can share with us today. Before Dr. Onya takes that question, I see Dr. Fajolu's hand up. Dr. Fajolu, can we have your question? And then we'll come back to Dr. Onya to respond.
Thank you, Rodi. Thank you very much, Dr. Onya, for this very thought-provoking lecture. And as everybody says, there's no yes or no, right or wrong answer to all the questions that you have posed. And I want to follow Dr. Onifade's line of question, especially when it comes to newborn care. So you have a newborn who has been delivered and has something you think can be treated, okay? And the doctors are ready to do this and that. Then the parents come and say, this one are picking, I beg. Then they disappear. And you're in a government hospital, is cash. I mean, you pay before you can get anything done. So some of them are like, they're not ready to waste their money for this. So you're in between trying to get them to do this, care for this child, even though you don't have 100% assurance that the child will live, but at least there's some chance that this child will live and may end up, there's nothing wrong with the brain of the child, maybe just had some major skeletal abnormalities and they just are not ready. So you are stuck with this child, and sometimes they discharge against medical advice. There's really nothing more you can do for this child. So it puts you as a doctor in a difficult position. Then when you have a frank talk with these parents and they are saying, doctor, please, anything you can do. I don't know whether we're at that stage where we can take that decision to say, oh no, we're not going to do anything again for this child. And this is, like Dr. Nufale said about adults, we're going to go the palliative route when the parents are saying, please do anything you can, and they're paying for this service. It's a different thing if it's government funds that you are using to take care of them. So it puts you in a difficult situation trying to decide when to do or when not to do. So, and I also think that we need to do a bit more of enlightenment to the population to let them know that sometimes you just have to go the palliative way. So maybe more people understand that. I know it's not going to be easy for anybody to say, okay, no, take off life support or don't even do anything for this person or not. But maybe if more people come out and share their experiences, then that may help families who find themselves in this situation. Thank you very much. It was a very good, beautiful lecture. God bless.
Thank you very much, Dr. Fajulu. I hear you. I'm going to ask Dr. Adejuigbe to kindly ask her question, and then Dr. Ngozi Onya, please go ahead and start to respond.
Okay then. Thank you very much, Dr. Onya, my ebon, for the beautiful presentation and the stimulating thoughts that follows. I just want to say that I can say that with newborn, I know we are working in an environment that affects our reactions to death. We are very religious people, you know that. Even when people are not very religious in other issues, when it comes to death and life, people become more religious. And I must say that I'm also a Christian, and I believe that there's nothing that God cannot do. So you see a child that you know for sure that this child, the prognosis from your training is that this child will not make it. But the parents want you to do everything possible. And like a mother, a 54-year-old woman who had never had a child, who had an IVF, and then she has a baby who has severe Bartter asphyxia. This child is already HIE stage 3. Everything, the child is convulsing, everything is just wrong. Where do you draw the line? You want to go all out, And yet, I've seen babies who we thought were very bad. The parents didn't even have money, just gather what we could in the world, just to do whatever, just to ease our own conscience. But the child made it. And even after, during follow-up, we see that the children are normal. So, I think the thing is, when do you decide? Maybe the circumstance. In every circumstance, we have to, take our bets. Sometimes it's going to be for good. Sometimes it will be wasted efforts, but the patient may be happy. The parents may be happy that at least the child had the benefits. Because some parents end up beating up their physicians or their doctors and nurses because they feel that they didn't do enough. Even when people are brought in dead in this community, they feel that you should still do something. So it should be seen to be doing something. So I guess it's a difficult decision. Thank you for the stimulating thoughts. Thank you. Over, Dr. Orode.
All right, thank you, Dr. Adejuigbe. Dr. Onya, the floor is yours.
Yes, thank you. I don't have any answers, obviously. This is what you call a conundrum. That's the honest truth. So there are no real answers. But this morning I was discussing with a friend of mine who's a dentist. She used to work for the government. And she told me a story about once when they rushed, I think she said 3 or 4 different people to the hospital at the same time, emergency room. And she was on call and there was a general surgeon. They couldn't find the maxillofacial surgeon. So one person had driven a motorbike into aluminium, cut his jaw was flapping, his tongue was cut, he was bleeding the neck and all that. Another one was somebody who had slept under a truck and the truck had rolled by him and his intestines were coming out through his rectum, through his anus. Another one was somebody who fell off a height and broke the head. And another one was an 11-year-old child who had been hit, run, and then broke a femur. And she said one anesthetist on call, one surgeon, they just took the 11-year-old child and they left the other 3 to die. And I'm saying to her, when we think of medical ethics, there are 4 principles: do good, do no harm, justice, and autonomy. When you think about justice, where does justice come in? Should it be a first come, first serve? Should it be the person who has the best chance? This is what they opted for, the person with the best chance. It's a judgment call. It will always be a judgment call. But I agree with Dr. Olufade that I think we should come to a point in pediatrics where we can talk about, I like the phrases they use in the UK. We need to be realistic. We are a religious community, and I think that's the real problem. It's a problem for the parents, the problem for we the doctors, because we think if we say to a patient that this, the prognosis will be poor, we feel they're playing God. That's the truth. We feel, who am I to decide whose prognosis is good or bad? But I think we should, as a people and as a community, as a profession, and as a professional group in Nigeria, we should evolve to the point where you can always leave room for prayers. But I think we should be able to say, it's challenging for us in private practice. Because by the time you are done and you give the patient a bill, does it not look like you did all those things so you can bill them? At that point, they don't remember that the patient needs to go ahead. Indeed, the father of that child had a huge bill and had refused to pay, and I've told them, don't call him. If he ever one day decides that, you know what, we should pay this hospital, and if he doesn't, we will write it off. Because, it's something that's trouble. Because how else do you convince him that you did all these futile things because he put pressure on you? The question is, I'm the doctor, not him. So when I had my friend Titi this morning, I don't know if she does the call to the dentist, but I sent her the link. When I had a chat with her, in the end, we said for each, it will always be a judgment call. And for each case, we will pray and be guided. We pray and be guided. Sometimes we will take the wrong. But not, we will take the right.
Love of my life.
I think as an association, we should now address the issue of life-limiting conditions and palliation for children and so on. Because this person I was talking about is 14 years old, so technically it's still a child. So life-limiting conditions and palliation to the children. I remember once I saw a child who had gone to India for, I think she had a neuroblastoma. She had had surgery in India, and they returned her to Nigeria and gave the father some drugs and so on and so forth, and said she didn't need any follow-up. And I looked at everything. And it was when the father finally came to me, of course there had been a recurrence of the growth. I told him that the reason why they said you didn't need follow-up is because they know it's inoperable, that it cannot be helped anymore. It was very hard. It was a very young couple. It was very hard. But you see, I look back and I remember that case, and I know I took the right call. It was very hard for them, but they accepted. So we kept giving the drug until we could give the drug no more and so forth. And so when the child finally came one day in coma, convulsing, obviously had the metastasis to the brain and so on. And the father said, what do we do? I said, hold your child, hug your child. I said, the last sense to go is hearing. So keep talking to your child. The mother take your radio, your phone, and play the things she likes for her. And the mother was doing that. And then the father, he was a Fulani man, very young man. The mother may have been 24 and 22, and the father 28 or something like that, really young couple. And the father said, "You see, my mother is a Fulani, what do we call them? Like a herder. I've forgotten what we call them now. Okay, and that the mother had told him not to go to hospital anyway, that they have very powerful and potent native medication. So he wants to take his child to Kano for treatment. And I encouraged him. I said, yes. So he said to me on Friday after work, we will leave. And I said, okay, this might have been Tuesday. I knew the child wouldn't last to Wednesday. So I didn't discourage him from making his plans to travel. But we just started palliating the child, sedating the child. And eventually the child passed on maybe on Tuesday night or Wednesday morning. And you see, I felt at peace because I think we did the right thing in that case. For this other child, other pressures came to bear and so on, and it was a slightly different situation and older parents and so on. I'm not sure I did the right thing. So like I said, it will always be a judgment call, and we can only pray that God will guide us. But I just thought it was something to bring to our consciousness that we now need to start behaving like an Igbo doctor. And I do agree with Dr. Fajolu that maybe in the UK, they can put their foot down because the government pays the NHS. I wonder if Dr. Nifade's brother had gone private, if they could still put their foot down like that to say, if you insist, do whatever you need to do. Those are all things, but I think as a community, if I'm sure that if I say to the patient that, look, the prognosis is poor, there's nothing much I can do, that he's not going to go to Professor Adeju Igbe's hospital and she says to him, don't mind how, she should have done this and she should have done that and your child will have lived. If I'm sure if we are all sure that we all share the same values and this is the way we've agreed to go, then it becomes easier to make those judgment calls. After all, let's face it, everything that we have today as our ethics were developed by people. It's not as if they didn't come down from heaven with us. People look based on their experiences where they are. And like I said, it becomes more imperative now with advance in medical technology. See how long they kept Ariel Sharon, or what was his name? Yeah, see how long they kept him on life support machine. Many things are possible. In this COVID pandemic, I've seen patients, every day I'm looking at the numbers and I'm seeing this patient going down. During this pandemic, we actually had 2 patients. That's a good one to tell. 2 patients who were kept on who stayed alive on ventilator for 6 months. 6 months. Luckily, they were being paid for. One was foreign, one was Asian, and one was Nigerian. They're being paid for by a company, but of course, that company got very upset because every month, millions were being paid to keep these people on life support. I have their videos still on my phone. They will eat food because by this time they were now on tracheostomy. They will eat food, even cycle on a stationary bike to try and to restore tone into their muscle. But they just could not breathe without a ventilator. Their lungs were totally fibrosed. And the only way they will have lived would have been to get a lung transplant, to which they were not going to get anyway in Nigeria. So after a while, the people got tired of paying. I also felt very guilty. But do you yank the tracheostomy tube off because you think they've lived long enough? We couldn't do that. So they moved them to another hospital. And then one of them the patient died. And then the second one, actually we extubated. The Nigerian we extubated before he even moved to the other hospital. So they discharged him home. But within a month, his son sent us an obituary. He died at home. His lungs were fibrosis. He didn't have enough lung tissue left to support him. But only you can only imagine how much that family had to pay to keep those 2 patients alive for 6 months. What was the benefits in the long run? Okay? We'll continue pushing it and doing the best we can. God help us, God.
Amen.
Thank you, Dr. Onya. As many of you know, I did residency. I did residency.
I thought I was saying at the end of this pandemic. But I don't know if my mental health is fine again.
It'll be fine. It will be fine. So I think I came across this a real dilemma in this regard. In a newborn, a child who had a life-limiting condition and whose parents also were very young, but in addition, who had both parents and both sets of grandparents alive. And the baby was being expected already. The diagnosis had been made. We were in Pittsburgh and the child was going to be born and transferred. One of us was going to walk the baby from the women's hospital to the children's hospital, where essentially a death watch room had been set up for the family. They were Christian and they were going to pray with the baby until the baby died. I don't think I had just had my second child. So my baby must have been about 7 weeks old, just come back to work, just had the baby, just come back to work. And it was a horrible day for me. I cried more than the bereaved because I couldn't take it. My emotions were all over the place. But I remember thinking how very beautiful it was that they had somebody to pray with them. They had soft music in the room. They had the room to themselves. And they were with this child, handing her from one person to the next until she finally died in her mother's arms. Each of her grandparents prayed over her. And I remember thinking, I've never seen this in my life. Much as I'm pained and I'm busy crying every time I leave the room, I thought it was very interesting. So, but if we're going to ever get there, then we have to have things like ethics committees that actually help to take this conversation forward at the level of every facility. And keeping in mind that we are religious people and that both the clinicians and the families are religious. I don't think there's any one of us who doesn't sort of hold strongly to their faith. And so in the event that we are in a position to, and I'm glad I see Dr. Waje and her hand is up, I'm sure she has something very interesting to say. In the event that we are in a position to get our families to begin to think about these things as children are admitted. So it's part of the admitting paperwork. You know, do you have an advanced will? Do you have advanced living will, advanced directives? You know, to what extent should you be resuscitated? Should this child need to be resuscitated? Many children actually come in who have chronic disease where they do not resuscitate requests. But I agree, it is hard in newborns. It is especially more difficult in an environment where there is capacity to, I think, more in the private sector than in the public sector. But I think that the way to begin to think about this is, one, to have ethics committees, and two, to begin to teach about this at the level of medical school, so that when people come out, they have had the conversation before and they're not met with shock the first time. The last thing I'll say is that every testimony is an anti-medicine testimony. And so we all keep that in mind, I think, when we sort of don't want to play God. But every time you hear a testimony in church, the doctor said he wouldn't live and he's here today. So I think that has also colored how we think about this. But so thank you very much, Dr. Onya, for bringing this stimulating conversation. Dr. Waje, please go ahead.
Hi, thank you so much, Dr. Onya. And I must apologize. I'm in the clinic and I missed out a large chunk of the presentation. But I was just wondering, you know, as people were asking the questions and responding, a situation that I had really was a child who had meningitis. And, you know, everything was done to, the parents wanted the child to survive, the hospital wanted the child to survive, and everything was done. But this child ended up being blind, mentally retarded, couldn't feed through the mouth, you know, just a mirage of problems. And the future, now this happened outside in the US with us, and every time you saw the parents, you could see the anguish that they actually, now thinking back, are wondering, maybe you could see that they were almost giving up. I mean, eventually the child died, but to them it was a huge relief. But it had taken so many years of literally carrying the child. Mother could not walk anymore. That was 24/7, you know, monitors here and there. And you know, so I'm just wondering, you know, where do we draw that line? You know, Dr. Onya said she had no answers for this, but then, you know, you're wondering, okay, should we not, knowing what's going to happen down the line, you know, should we be telling these parents all of these? And then, you know, especially in a society where we reject it, heavens forbid it. My pastor said he's leaving, this child is for signs and wonders, you know. So I'm just throwing that open and wondering what other people's comments are regarding that.
Thank you, Dr. Wade. I see Dr. Nifade has put in a message here. I suspect we should be talking about DNRs and not advanced wills. And yes, perhaps because we're pediatricians, we should be talking about, you know, DNRs. But I think Dr. Ngozi also, Dr. Onya mentioned at the start of this that this is just a broad flat out medicine, and many of us are also practicing sort of adult medicine as we go along. And Dr. Wajé, I hear you when you say, you know, you look down the line, but I remember him, I'll never forget him. His name is Brady Polk, and he must be now 17 years old because he was the same age as or maybe he's 16 now because same age as, just a year younger than my son. Brady Polk was 349 grams when we finally weighed him on the Kinikon day of life. I don't remember what, maybe 18th day of life or something. 349 grams. And he had a trick. We couldn't take him, or not a trick, a tube, a breathing tube. We couldn't weigh him without the tube because he needed the tube. So, but Brady Polk went to kindergarten and all he had was thick glasses. I will never forget that. And he didn't have any other issues. So I don't know. I mean, maybe now that he's 17 or 16, he may have not be able to go to college. I don't know. But I remember this child was hitting all his milestones as he was coming to clinic. So I don't know, but I mean, I don't think we will try and do a 349 grammar. Of course, that was also Pittsburgh. That's a bit unusual. But again, there are some things we see, and like Dr. Fajolu said, a child who has a brain and who can see everything, you know, a brain that is intact, she's cognitively there, and she can see what is going on and hear what is going on. Do you walk away from such a child? I mean, I just don't know. But it's 4 o'clock now, and I'm going to look to Dr. Eletu to find out if we still have more time for further conversation or if we have to wrap up soon.
Thank you much. Chair, do you want to say anything, sir?
Well, I think, you know, if there are a few more burning questions, it's a very interesting session. And I want to thank Dr. Onya for raising these issues for conversation. You know, it's a dilemma when it occurs, especially when it has to do with out-of-pocket payments. You know, so perhaps one of the things that will help us to reach consensus easier is if, when, you know, measures to develop our health system in such a way that regardless of your leading in life, if you are confronted with such decisions, the issue of out-of-pocket expenses is taken care of somehow, either by insurance or by government dealing with it. Then it's easier to face the issues better. And also the issue of our beliefs and faith is very strong here in our environment, and often it interferes with the kind of logical approach that ethics demands in Western countries. And believe it or not, if you are the first specialist to see such a child, and you give bad news, no matter how well quoted, be sure that they are going to go to another place to confirm what you have said, because they just will not take it. So we have a health system that handicaps all of us. And that's just my own comment on the issue. So if there are one or two other burning questions or comments, I think we can take them before we round up. Thank you, Dr. Elito.
Thank you very much, sir. So already.
Yes, sir. So thank you very much. Thank you very much, Dr. Onya, for that thought-provoking from the heart presentation. I think that we are all each of us is the richer today for having attended this conversation. I'd like to thank also the other members of the private pediatric group for attending. Thank you all for coming and for making the time to be with us and to join your voices to this conversation. I think that it's hard for us because we're pediatricians, and normally when we're called, yes, children are sick, but we're not expecting that we're going to pronounce life and death in their regards. But I think we're all in agreement that our medicine is progressing and our healthcare systems are becoming more advanced. In Nigeria, we can do more for children, and we're in a position to do more. And to that end, then we have to start thinking about ensuring that justice is served and that we are above all doing no harm. So the time probably has come now for us to start thinking very seriously about engaging ethical committees, ethics committees, and ethical conversations in our institutions, in our teaching institutions especially, and so that young medical students and prospective clinicians are having these conversations and sort of in context, given where we are today. We are a highly religious society. With all this said, let me thank you all once again for attending. Dr. Ngozi Onya, thank you very much. And thank you to all the contributors. And see you again at our next private pediatric group meeting. Thank you.
Thank you.
Thank you very much. Just to say that the next presentation will be on the 30th of September, which will be the last Thursday in the month of September. And we look forward to seeing each and every one of you. Thank you very much. God bless.
Thank you. Thank you very much. Bye-bye. Bye.
Thank you, everyone. Bye-bye.
Bye-bye.
Bye.
Bye.
I missed it.
Femi, are you back?
Yes, I am. Thank you, sir.
Oh, I see. Cabo.
Yes, sir.
Don't forget the 15th. So.
Not at all. Not at all. Yeah. Yeah.
So anyway, say hello to your family.
Okay, sir. Thank you, sir.
Very good discourse. Very good.
Yes, excellent. Yes. And thank you, sir, for joining us.
No, it's a pleasure. It's this is what I've been praying for. Yeah. All right. Have a nice day.
Okay, right. Sir. Okay. Bye-bye. Yeah.
Bye-bye.
Yeah. So bye-bye, everyone.
Bye-bye.
Bye.